So I'm Julia Newton Bishop. I'm a Professor of Dermatology in Leeds, and I do a lot of research, and I'm just about to put in an application to the MRC for a particular project which is called an MRC Stratified Medicine Programme. So this is to find biomarkers, and I'm going to explain briefly what I mean by biomarkers, and this is a prelude really to seeking your views on biomarkers. These are tests that give you some information about whether or not a treatment is likely to work for you. But it's not an easy thing. It's all about uncertainty, and I would like to collect some information from patients about what they think about biomarkers. And so after this Congress, if you don't express a wish to withdraw, I will send you a questionnaire and seek your help in returning those questions. So this is just a start to that. So when we're making choices, and on the right I've put choices about suppliers of electricity, we tend to do some research. We tend, well, some of us do. We tend to need information to make a decision. And that applies particularly, of course, in respect to health. So all decisions have uncertainty. Making the wrong decision has consequences, and we're more likely to make the right decision for us if we have information. Does this not work? Next slide, please. So when they're about your life, these decisions are extremely difficult to make, and the consequence for you and for the NHS are considerable, and therefore research is important because it can reduce that uncertainty. Last year I showed this slide, which was from the NICE guideline, which was about illustrating the fact that things aren't always cut and dried. This was something I showed, as I said, which weighs up on the left the pros of having sentinel node biopsy, and on the right the cons of having sentinel node biopsy. Next slide, please. Essentially, yesterday, I think you heard an awful lot about the Larkin trial, looking at combinations of immunotherapy. And you will know that, actually, as it says there underneath the pros and cons, that a significant proportion of melanoma patients given immunotherapy get no benefit at all from just Nivo or from a combination of Nivo and Ipi. And our research is intended to try and find a test that predicts those patients, and then they might try some other form of treatment. Next slide, please. So this is the name of the consortium, and the proposal will be to try to use blood and tumour samples from melanoma patients starting immunotherapy to identify biological differences between patients that will predict response to treatment. And we need thousands of patients to help us with this, because you need statistical power, and you need to make sure that you try and collect information on all sorts of different melanomas, because melanoma is not one form of cancer, it's lots of different forms of cancer. And we'll ask the patients to give blood and to give consent to use of their tumour tissues, so that when you've had a melanoma removed and it goes off to the laboratory, it sits in the NHS laboratory for years in a little bit of paraffin, and that's a tumour block, a little bit of paraffin in which the melanoma has been embedded, and that's one of my technicians taking a tiny little sample of that tumour. And we would then do some research on that tumour and put it into the database. Next slide, please. And the sort of issues that we consider in setting up this research are illustrated in this slide. And it's about these sorts of things that we'll collect some information. So we have to take consent, and it has to be properly informed consents. Patients have to really understand what they're consenting to. we have to access their stored tissue. We seek their consent to access their stored tissue. And there are issues around that related to the Human Tissue Act and whether or not we might use up tissue the patient might need for another purpose later on. So we try and weigh up all of these issues, but we need to seek your views on what we're doing. At the bottom, it's about data protection, and we might hear something about that in the second talk. We have to make sure that the data are absolutely secure, but that they're good data and that we use them. We have to think, will that make the clinical trials that we're trying to do more difficult? Will having blood tests put patients off? If someone asks you to have some research attached to your therapy and it means more blood tests, will it put some people off? Would it put medical teams off? Are they less likely to do the clinical trials if it entails extra work collecting samples because they're working in an already overstretched system? Can we afford the research? Can we afford not to do the research? Can we afford to waste expensive drugs when it's not going to work? Those sorts of issues. Next slide, please. I think we'll move on. Next slide, please. Next slide. So in the end, when we've collected information from lots of patients, we then have our own statistical, scientific difficulties of trying to find a way of presenting the information where you weigh up the risks and benefits of the treatment, and we have to make it absolutely as clear as we possibly can to patients using our tests in the end. But there are many issues around this. So supposing we had a test that said, that predicted that for me, I would have a 1% chance of responding to a particular treatment. What would I do? It depends how toxic it is, how ill it's going to make me feel. Is there something else? If there's not something else, am I going to take that 1%? The NHS may not think it's a good idea to spend the country's money on that drug because it's very unlikely to work. NICE might say it's not suitable, it's not reasonable to use that. So there are all sorts of issues about what individuals think is an adequate chance. What we're going to try and do is produce something called a clinical decision tool where there are lots of treatments, because in 5 years there will be lots of immunotherapies, lots of different ones, and what the tool will say is what's most likely to work. Perhaps that's an easy way out. But actually the threshold at which you say this treatment's not likely to work is a very difficult one, and that's something I might also ask. Of course, it depends on the person. It depends how old the person is, it depends what their personality is, whether they've got other health issues, how they weigh up those pros and cons. So we're trying to find tests that make it easier to make a decision, but actually even when you found a test, it's quite difficult to apply it because of those balances, checks and balances that we have to put in place. Next slide, please. So if people who are willing to reply to my questionnaire, I would be grateful. I would be grateful for your views on clinical research. We've talked about treatment last year and I presume yesterday. Research is also very important. The government is very worried about data security in terms of the NHS and research data collection, so sometimes it's actually quite difficult to any research now because of all the governance issues you quite rightly have to go through. So you have to make sure you get it right in the beginning. So any comments before we go on to the main session? Hi.
Are you going to be doing this retrospectively, so those of us who have had immunotherapies and either responded or not responded, are you going to go back and look at that tissue and see if it is covered?
Yes, we might do that at some point. What we would like to do is to find a test that we can use on the blood, because it's a lot easier for the patient and you can keep doing it to see whether the situation changes. So we will take new blood samples. We also think that no single test is ever going to give us the answer. It may be that we need both blood and tumour tissue. So we will do it prospectively, going forward, as they say now. But if we then have a test that says, actually, this tumour test, for example, is really good, then we would like to go back and use your tissue. But then that's a good example of the issues, isn't it? How do I find you? And how do I find your tissue? And how do I get your consent to use it? It's difficult to get it right. But in the end, as my clinical experience tells me that most patients want research to happen. And it's just a question of how you make it safe, respectful research that is sufficiently big to produce a definitive answer. What we've done in the past is we've had too many small studies and you can't really tell what the answer is, and we want to make big studies which are much more powerful. National studies, which is what this is about. Hello.
Thanks. We had a number of talks yesterday about biomarkers and particular individuals that are looking into it as well. Speaking for my wife, I know she'd be happy for all of you to get her bloods and samples of her tumours. What's being done to synergise that?
Well, this is an MRC national competition. So the reason I wasn't here yesterday is the grant has to go in this weekend, and I have been working to get a national group together, in fact an international group together. So the idea is that recruitment would occur through melanoma MDTs up and down the country, because the government puts money into research data collection in all the clinical units. Yes, you don't want a sample that's based, I don't know, say on the Marsden, because the patients in the Marsden aren't necessarily representative of the whole country. So you want a whole country test, really. Britain is one of the few countries in the world that could do it, actually, because of our NHS and because of the way the cancer services are organised. Yeah.
This is about us as patients taking ownership of our care, taking ownership of our tissue samples and of the research that is going on. So if we want certain things to happen in that research, let's feed it back to Julia within the survey, and let's say, yes, you can use my tissue, and yes, let's drive this forward. And she's going to feed back to us as that research goes on, so that we're going to find out what the results are from that, so that we are helping to drive forward what is actually going to be happening. I think we're going to have to stop there.